recorded and eventually shared on our chapter social media page, so we can view this at a later date. Let's see, a few housekeeping issues to everybody online so far. Please remember to keep yourselves muted during the presentation to minimize disruptions. We will allow time for Q&A at the end of the call, but feel free to enter any questions you may have using the chat feature, and we'll do our best to answer as many as we can at the end of the presentation. And just note that these town halls are not meant to diagnose or treat anyone's specific health issues. If you have questions regarding your personal health situation, we recommend that you contact your professional healthcare provider. And the CF Foundation is committed to providing a safe and inclusive environment at virtual events. By attending any CF Foundation event, you agree to follow this guidance. Now it is my pleasure to introduce today's presenters to discuss nutrition in the age of modulators. One size does not fit all. We are lucky to have Jessica Shape, our adult advanced CF dietitian at Northwestern Memorial Hospital, and Lauren Thill and Jillian House, pediatric CF dietitians at Ann and Robert H. Lurie Children's Hospital of Chicago. So without further ado, I will turn it over to Jessica to get us started. Thanks, Jessica.
Yeah, thanks everyone for joining. We really appreciate everyone's involvement and interest in this topic. It's obviously near and dear to our heart, so we are very excited to have everyone. So basically, we're just going to review the legacy diet first, and then we're going to discuss nutritional changes with starting highly effective modulators, also known as HEM or HEM. And these include calorie and protein absorption, weight gain, body dysmorphia, GI changes, which includes transition from pancreatic insufficiency to pancreatic sufficiency in some occasions. And then we'll summarize, and then we'll leave some time for Q&A for everyone. So jumping right into it, the legacy diet, which I am sure almost everyone, hopefully most people are pretty familiar with in the CF world, essentially high fat and high calorie focus. And why is that? So malnutrition is historically a characteristic that is closely associated with CF. And way back when, it kind of evolved into specific nutrition strategies that include unrestricted, high calorie, high protein, high fat diets. And this was because they were placing emphasis on weight gain, weight maintenance, and BMI goals due to its association with improved lung function. So legacy diet specifics, as you can tell in the pictures below, high in total calories, high in saturated fat, trans fat, added sugars, refined grains, and relatively low in fruits, vegetables, whole grains, and dietary fiber. So this is kind of a generalized view of it. Not everybody's as specifically looks like this, but majority of them I have found does look very similar to fast food, convenience food, processed foods, packaged foods, mainly because that is what was the easiest to get those calories in at a young age and pretty similar through adulthood. Highly effective modulators. So most of you know what these are. These are basically medications that target changes in the expression and functionality of that CFTR protein on the cell surface, and that itself is going to improve the CF manifestations that we know classic CF to look like. Pretty much 90-ish% of our CF patients currently qualify for modulators. And despite that, it's important to note that some patients that do qualify may still have significant side effects, which affect their ability to take modulators, and some may also be non-responders. Trikafta, what everyone is here to learn about. So also known as elexacaftor, tezacaftor, ivacaftor, because that's a mouthful, we simplify it to ETI. And this was basically the first triple combination therapy made available for CF patients that was actually approved in October 2019, which was right before the CF conference that year, which was a super exciting conference for everyone. I had a great time there because of this. We got to learn a lot about what was going on with this new combination therapy. Interestingly to note, the only specification from a nutrition perspective was that it must be taken with a fat-containing meal. And the important thing to note here is that Vertex, which is the manufacturers of Trikafta, fat grams, like specific recommendation for efficacy, because that is what is going to make it more effective, is actually still remains unknown, which is very interesting because we've always been pushing high fat, and then Trikafta comes along and we still seem to be pushing it, but their guidelines are not as specific as dietitians would like. So common nutrition changes after starting Trikafta, obviously we know weight gain being one of them. We've seen elevated vitamin levels, pancreatic changes, function changes, and a lot of GI changes that range from constipation, diarrhea, a mix of the two, and improved motility. So now I'm going to hand it over to Lauren and Jillian.
Hi guys, I'm Jill. This is Lauren.
Hi.
We're the pediatric dietitians at Lurie. So yeah, talking about, just do you mind clicking forward? So you can keep going if you click one more time. I think one more. Yeah, there we go. So talking about, back one, sorry.
Got it.
Talking about nutritional changes in the pediatric population. For us, it has always been really important to make sure that our patients are getting that high calorie, high protein diet that Jess was talking about, the legacy diet, and also making sure that it does include fruits, vegetables, whole grains, lean proteins as well, because our patients are obviously in a stage of extreme growth. And so we know based on BMI percentile, we know that having a BMI greater than the 50th percentile is directly related to the FEV1, or how well our lung function in our patient is going. So it's really important to us to make sure that our patients are not only getting enough calories and nutrition to grow, but also to be able to maintain that lung functions that we look for. So we really emphasize trying to get that BMI above the 50th percentile, but we do also want to emphasize making sure that our patients are getting the vitamins and minerals that their bodies need to grow properly. So for patients that have been on modulators, we have seen some patients that have increased their BMI above the 84th percentile, which some of you may know, some of you may not. A BMI above the 85th percentile, we would classify as overweight, and then a BMI above the 95th percentile, we classify as obese in the pediatric world. So when we're looking at the patients that are technically categorized as overweight, we start to transition to a diet that instead of following the legacy diet that's high calorie, high protein, we try to stick towards high fiber, high protein. So making sure we're getting lots of fruits and vegetables, using whole grains and lean proteins, low in saturated fats, trans fats, refined grains, added sugars, and encouraging physical activity, so that we're also, we're making sure that we're still getting all of the nutrients that their bodies need to grow and function properly, but not kind of setting them up for failure in the form of being overweight or obese when they head to that adult world, where Jess would then be taking care of them when they transition to adult care. So if you want to go to the next slide.
Yeah, so continuing on with growth trends with modulators in our pediatric population, we wanted to include these graphs, which are showing from the CF patient registry report from 2023, our median weight percentile and median BMI percentiles for patients 2 to 19 years old. So in our pediatric population, our Lurie Center in red compared to eligible other CF centers in green, showing that we have always been slightly above the median of all eligible centers, but not too much of a drastic increase or decrease of both weight and BMI. So this really just shows that it does vary patient to patient with what we are recommending for our diets and our growth trends. So like Jill said, we could have some greater than the 84th percentile, but we also could have some still struggling trying to get that high calorie, high protein diet. So yeah, so going and saying that's very variable patient to patient.
So another change that we're starting to see with patients that are taking modulators is when we're checking their annual vitamin labs. We are starting to see some patients who may have elevated labs instead of lower labs, which is what we're typically used to in the CF community. So the majority of our patients are on CF specific fat soluble vitamins, vitamins A, D, E, and K. And they are very high doses of those vitamins for our CF patients. So when we are starting to see these changes, we've kind of said to ourselves, what do we need to do now that we're starting to see their labs elevated instead of decreased? So for the patients that are on CF specific vitamins, we'll start, and we notice that they're having higher labs. We'll start to decrease the amount of times that they're taking their CF vitamin per week. So maybe instead of taking it every day, we'll say take it every other, or start to take it only 3 days a week or twice a week. And then we recheck vitamin labs in 3 months after that, after we make a modification. And then if they're still elevated, we may just transition them to a regular over-the-counter age-appropriate multivitamin. And some of the vitamins that we use are pictured below. But we are starting to see changes in increase in vitamin levels with patients taking modulators. So that's been interesting.
Next, our pancreatic enzyme replacement therapy, known as PERT. The changes that we've seen with modulator use in pediatric population. So we know fecal pancreatic elastase is a diagnostic test for exocrine pancreatic insufficiency. Normal is going to be greater than 200. Moderate insufficiency is a range of 100 to 200. And then diagnosed severe pancreatic insufficiency of less than 100. So there's about 85% of people with cystic fibrosis will have exocrine pancreatic insufficiency, meaning they'll need enzymes. And so we'll say if they're less than normal, so less than that 200, we will start the enzyme replacement therapy, treating with enzymes to cover about 2,000 to 25,000 or 2,500 units lipase per kg per meal, or that is average of 10,000 units lipase per kg per day. And all patients are different with those as well, based on symptoms and growth. But with our CFTR modulator therapy, they may improve partial restore of exocrine pancreatic function. So we have had some patients in the last couple of years actually telling us, hey, we missed this dose, or I'll forget doses with lunch at school, and I won't have any symptoms of bloating, diarrhea, oily stools, and then we'll see them in clinic. They're still growing great, not saying any GI symptoms. So that got us to start thinking, well, could there be a relation with our modulators and enzyme replacement?
Next slide. So because of this, and thanks to Stacy Bickle, who is our nurse practitioner who leads QI, and also Dr. John Paula, together with those two providers, Lauren and I, we have all started working together on a quality improvement project to look at the restoration of pancreatic function in our pediatric population. On patients that have been on modulators. So typically we check a fecal elastase or stool elastase level prior to them starting a modulator. And then we are now starting to try to come up with a protocol. And if you could click one more time, Jess. Starting to come up with a protocol to check our patients. And we're trying to figure out how frequently we would like to check our patients based off of this quality improvement project to see if patients are becoming pancreatic sufficient after being on modulators for 6 months or 6 to 12 months. And if we are able to decrease or take them off fully of pancreatic enzyme replacement therapy once they have been on those modulators, and if we are seeing any improvement in their stool elastase. So that we are still collecting data on. We don't have all of the data yet. We have definitely seen some patients that after, oh, sorry, if you can go to the next slide. I'm getting ahead of myself.
Yeah, so we are collecting a lot of poop samples, stool samples from patients, which can be difficult, but our process measures is going to be the percent of eligible patients on modulators with pancreatic insufficiency or even a history of pancreatic insufficiency screened in clinic each month. So this shows the first one on the top, our data through May. And we, like Jill said, we are going to continue collecting data and actually presenting poster at this year's NACFC conference. So the blue is showing number of patients on a modulator for greater than 6 months.
Sorry about that.
It's okay. And then orange is showing the number of patients screened that have changed to pancreatic sufficiency. And then
in the top chart.
Yes. And then the bottom is going to be our outcome measures. So the percent of patients screened who have changed from pancreatic status, pancreatic insufficiency to sufficient. So this is a great visual. Orange is showing persistent pancreatic insufficiency. So they've been on modulators for greater than 6 months or even years. We collect that stool again, and it's still pancreatic insufficient. We'll still continue enzyme replacement. Blue is the change to pancreatic sufficient. So with those ones, we are titrating off or discontinuing enzymes. And what's even more interesting is this gray section, which is improving. So from severe to that moderate, like I talked about earlier, pancreatic insufficiency.
So this is not the final data. We're still collecting information, but it's really interesting to see these changes in our pediatric population so far. Next slide. So overall, and I know that Jess kind of has much more to speak to with the adult population, with monitoring nutrition status in patients taking modulators. But for the pediatric population, if you want to click a couple more times, Jess, I think one more. So overall, best practices for the pediatric population monitoring nutrition status. I know we received a question about kind of what the standard of care is and if we're really monitoring BMI. The answer is yes, and we want to monitor, especially in the pediatric population, everything. So yes, we're looking at BMI for age percentiles and weight for length percentiles. We want those to be above 50%. Above the 50th percentile in patients less than 2 years. And then for patients above 2 years, we want them to be greater than 50, or I'm sorry, between 50 to 84 percentile. But that's not the only thing that we want to look at, because we know that BMI is not the only indicator of nutrition status and health and should be used in addition to other indicators. So of course, like I mentioned, we're also monitoring vitamin labs. We do check our vitamin labs yearly in all of our patients and adjust those vitamin labs based on, adjust the vitamin levels based on what our labs come back to be, and recheck if we adjust them, we recheck labs every 3 months. Also reviewing dietary recall. So we do this almost every visit with all of our patients, making sure, like I mentioned earlier, that we do want our patients to be getting a wide variety of foods, including fruits, vegetables, healthy fats, lean proteins, even while encouraging a high calorie, high protein diet, just so that we can make sure that they are getting the nutrients and vitamins that their body needs to grow, while also setting them up for success with having a healthy BMI, as we know it is correlated to their lung function, and making sure that they're growing properly. We do also do every visit a nutrition-focused physical exam. So we monitor our patients to make sure that they are gaining weight properly, that they look appropriate, that they look well-nourished, monitoring for any edema, any excessive weight gain, and also for if our patients are having any weight loss, monitor for any muscle or adipose tissue wasting. And then now we are doing our pancreatic function quality improvement. So that is something that we've started to help screen for any changes in nutrition status. So kind of handing it over to Jess.
Yeah, really cool QI project. I'm really curious what's gonna come about. You guys are doing a great job. I'd love to see it. So yeah, onto the adult side, a little different pace. Basically a lot of the calorie, protein absorption changes in the adult world, multiple things come into factor. For one, I find that my patients are requiring less salt intake as the modulators are actually improving that salt channel function. Another thing that comes into play is lower calorie needs. Like, we've talked about even in the peds world. With that improved lung function, they're not exerting as much effort, they're not using as much energy, they're having less exacerbations, which is overall improving their hypermetabolic state. So similar to Lurie's registry data, we have ours as well from 2023, ours being that red line that you can see. And this is the percent predicted FEV1 for lung function. And you can see like the gradual improvements, specifically an uptrend starting in 2019 when Trikafta was introduced. And now we're reaching the 90% area. So it's really cool to see with our patients feeling better, but it also has a lot, repercussions with the current diet that they're taking in. Additionally, we are finding that the mucosal lining of the GI tract is not as thick as it once was, and this really comes with the decrease in mucus production, and this really improves their overall digestion, absorption of nutrients, and with that comes, for one, weight gain. So that is a piece of that puzzle. And two, improve vitamin levels. Like Jillian and Lauren were saying, we do see these changes in their vitamin levels or fat soluble vitamin levels that we're kind of attributing to improved absorption and the high dose vitamin level or vitamins that they're taking in terms of supplements. So we do see some changes going on there, which is great to see. Pancreas function may improve. I use may very strongly in the adult world. I have not had as much luck as Lauren and Jillian with what we've seen in the adult world, but it may be able to decrease the amount of enzymes that people are taking. But my patients, I very rarely have them fully get off of enzymes. I don't find that their pancreatic function is returning fully, mainly because of the damage that's already done as the adult population. So it's a little tough because a lot of people are hearing, oh, my patient got off of enzymes or my family member got off of enzymes. Like, can I do that? So it's been a difficult discussion, but I do think that it is improvement to how they're feeling with the improved GI tract. And also it is promising to see that they're being able to decrease their enzymes, less pill burden. So it is nice to see. And as you can see here, this is a similar thing, the lipase units per kilogram per meal. And that's how we basically dose their enzymes. And we can see a downward trend starting 2020-ish and after. So that's promising. I do kind of reiterate, don't titrate on your own. Please discuss it with me before doing it. I have found that many people feel very confident in their ability to adjust their enzymes. And a lot of people have talked about, oh, I think I'm going to stop. And then I have to kind of educate them on our pancreas isn't fully functioning. It's not producing those enzymes needed to break down your food. And you will see some repercussions and discomfort with that. So lots of education going on there, but it is promising to see that we may be able to decrease their pill burden. Weight gain, the holy grail with Trikafta. So obviously weight and BMI are certainly trending up after Trikafta initiation. We have seen that pretty much across the board. Obviously not everyone, but a very large majority of our patients. And this provides honestly a really difficult balance with what's appropriate weight gain, like what is good weight gain, but we still want to maintain your pulmonary and cardiovascular health in this new era. And there is a lot that goes into that, which we will get into. But some contributing factors to this specific weight gain, which I know a lot of people had questions about when they first started Trikafta, one being their unrestricted, high calorie, high fat, nutrient poor, and highly processed diet. That's that legacy diet that a lot of my patients haven't really steered away from. They're continuing to eat what they know, and what they know is what they've been taught, early on with CF, and that is that unrestricted, super high calorie diet, which now in this new era of highly effective modulators, we're questioning the need for that, especially in the adult population. Another factor, improved absorption of calories and other nutrients, like we talked about. Low levels of movement and exercise. which I am finding is very common in CF. And a lot of my patients really only use their best therapy for airway clearance. So really trying to factor that in terms of, are you even working out? Are you moving? Do you leave your house? Especially in the era of COVID, it was very difficult to get patients to move, let alone leave their house. And I can understand with CF why that was a big deal. So we're kind of in the new post-COVID area, but able to get out and move around a little bit more, which is nice. And also lower metabolic rate with improved lung function and less exacerbation. So this is going along with, their continued high diet or high fat, high calorie diet with this lower metabolic rate that's kind of causing this accumulation of weight. And this is a really interesting graph that we saw in 2023, our registry data as well. We're seeing an uptrend in this BMI for most of our patients at Northwestern. There are some dips here and there. I think a lot of that is, after COVID, I think a lot of people maybe started exercising and kind of changing their diet, we hope. But you can see that trend moving upwards. And this is another really interesting graph that I don't ever think any of us ever thought we would see in CF. So basically, this is the percent of patients with a BMI greater than or equal to 30, which is that classification of obesity. So since 2019, you can see that steady rise, and that was obviously when Trikafta was approved. So this is something, obesity is not something we'd ever really discussed in CF, and now it is a pretty hot topic. So, lots of discussion going on around what do we need to look forward to in terms of, proper treatment, and how do we, kind of make sure people are doing the right things to help their health pulmonary wise and now cardiovascular wise. So recommendations after modulators. This is what Jillian and Lauren were referencing in terms of my long list of changes with the adult world. First and foremost, well-balanced meals and snacks, really trying to focus on, like they said, inclusion of, whole grains, fruits and vegetables, like things that we never really kind of discussed in CF. It's really like, eat whatever you can to maintain your weight. But now we're focusing more so on what does your plate look like? Stress management, I found in the adult population, that is one of the biggest important things to discuss in terms of that, along with adequate and quality sleep. I feel like those sort of go hand in hand, but also, stress management with jobs and balancing everything. CF patients have a lot going on. So it is helpful to kind of use, our social worker to help with a lot of stress management stuff that we can do. Encouraging physical activity. I am not a physical therapist and I will not pretend to be one, but I do talk to them about trying to get outside, move a little bit. I aim for, at least like 15 minutes. Can you get outside, walk around for 15 minutes to start most days of the week? It's free, it's accessible, it's easy to do. You can go as slow, fast as you want, but just really trying to encourage them to move. We're not asking for an hour gym session or, hour-long classes, but just something to get their bodies moving. Weight loss strategies. I've had many, many of my patients come to me and ask, how do I lose this weight? I hate this. Why am I going through this? How do I get rid of it? Things that they've never really needed to discuss again. How do I lose weight? No one's ever talked about that in CF. So really focusing on portion sizes. Obviously, we'll get into diet quality in a minute, but intuitive eating practices is something that I've talked to my patients a lot about. And some, family members were in the room at that time, and even they were like, oh, I could utilize that too. But really just mindful eating, trying to be present during your meals, not be distracted, really honoring your fullness and hunger cues, even acknowledging what those are and how those feel. So these are a lot of strategies that I feel like CF patients are not super familiar with. So talking about that in their clinic visits is something that I've been trying to do. Decreasing snacking, mainly is this habit or are you just hungry? I have so many patients that are like, oh, I'm in a habit of just eating and snacking and making sure I'm getting my snacks. And now with this weight gain, I kind of rephrase it of, do you feel like you need that snack or are you doing it out of your habits of, growing up with CF? And then, like I said, diet quality, trying to step away from this legacy diet habits. Instead of adding butter and margarine for extra calories, why don't we switch to just some olive oil for, heart healthy fats in smaller quantities? Instead of going out and getting fast food, foods high in salt, sugar, saturated fat, why don't we focus more so on home cooked meals where you can control what you're doing in terms of including whole grains, lean proteins, fruits and vegetables, low fat or fat-free dairy, heart healthy fats, etc. Planning meals instead of just having frequent meals and grazing. I find that especially in the adult world, grazing and just kind of snacking throughout the day and not having actual meals that are satisfying you and really filling you up is what the downfall is for almost most of my adult patients, especially with work schedules and if they have kids and whatnot. So I feel like it's really hard to implement, but once you can kind of get into a habit, I found that it's been very beneficial for my patients. And then really trying to change their mentality. What will make me feel my best versus, oh, whatever I want to eat to maintain my weight. So that's a battle that, this is something they've grown up thinking of, oh, I can eat whatever I want. I just got to maintain my weight and my BMI for my lung function versus what do I feel will make me feel the best, give me energy, etc. And then similar to what Jillian and Lauren were saying, adjusting vitamin regimens as appropriate, kind of if we need to wean off of their high fat soluble vitamins and kind of switch to over-the-counter multivitamins and spot dose where we need to, we will do that. And then, like I said, adjusting PERT as needed and lowering caps if we find it appropriate. Body dysmorphia. So this is something that I have found in the adult world. And like I said to Jillian and Lauren, I hope that you guys aren't dealing with this as much as I am, but CF patients obviously have many, many barriers to deal with. A lot of them, some physical, a lot of that is physical. Chronic illness with frequent hospitalizations, being in the hospital long-term, if they've had a transplant, dealing with all their medications or scars and GI stuff that comes with transplant meds, a financial burden that they're trying to manage and maneuver as an adult, the psychological barriers and the pressures of not only growing up as a child with CF, but also living as an adult with CF, but also a long-standing history of issues with body image. So CF patients have been taught from the way beginning that we need to place the highest importance on BMI and your BMI goals. And that obviously has a lot to do with the optimizing their lung function. So we've had providers and parents kind of communicate that their health is directly correlated to reaching these goals in order to optimize their lung function and keep them out of the hospital. And these goals are listed below for females 22 or above in terms of BMI and males 23 or above per the CFF guidelines. So this weight-centric care places a whole other, film of pressure on the patient's ability to control their weight and BMI. And let's talk about BMI for a second. So BMI is actually a very convenient number used as a determinant of health, and it really just utilizes a patient's height and a patient's weight. But it is very important to note that it is far from perfect. So a little history here. The BMI, the background of BMI was actually developed by a mathematician in 1832, and this was really to measure and characterize, just a general population, the average Caucasian male. It was not meant to determine health status for an individual patient or person. It was then renamed BMI in 1972, and that was starting to be used as a proxy for percentage of body fat, which was then quickly adapted by doctors to measure body fat in patients. So the ironic thing here is that BMI itself lacks pretty important factors such as body composition, percentage of fat, percentage of muscle. And very, very important decisions are being made in a CF person's life by their healthcare team based on a patient's BMI without truly understanding its limitations. I do think that there are places and certain scenarios that it is important to classify their BMI as something that is predicting their health, but obviously it's not for every single person, which is why I feel strongly about individualized care, which we will get into in a second. So incidence of overweight and obesity have obviously increased over the years in CF, which I know all of us as providers have seen. Currently, about 13 to 18% of the CF population is classified as overweight and obese. And those numbers are 4 times more as prevalent as underweight status in the CF adults in America, which is a pretty astounding thing to hear as providers in CF. It's not something I'd ever thought I'd hear, but I do find that this is the difficulty with that transitioning of their diet and lifestyle, from what they were being taught to now kind of transitioning, oh, I got to think differently. How do I incorporate healthy foods and how do I eat better, when their historically focusing on just that legacy diet that we discussed earlier. Body image. So the definition of body image is actually one's perceptions, thoughts, and feelings about their own body. And CF patients have a lot of risk factors for developing a poor body image. One aspect of that is physical. They've dealt with growth failure, pancreatic insufficiency, weight fluctuations that change very fast and very quickly, multiple medications that they need to take in order for their body to function properly. But also that psychological aspect as well. Very high risk of anxiety and depression. I think about 30% of the CF population has been diagnosed with anxiety. An intense focus on weight and BMI, a lack of control over their health, and their health being surrounded by the terms morbidity and mortality from such a young age, which can do some damage in someone's mental health. So with all of this, they do have a really high risk of developing disordered eating disorders, and a very unhealthy relationship with with their body and food and diet. So my recommendations for this aspect of it, like I said in the last slide, was focusing on individualized care. Individualized calorie and weight goals. Not everyone is going to require the same calories, the same nutrients, the same weight that they need to stay at for their best health. Trying to avoid these BMI classifications and weight-centric care as able. Of course, there are some situations where it is important to utilize that BMI classification if it is getting, I guess, out of hand is the way to casually put it. But if it's going to impact them negatively in a different fashion, such as their pulmonary or cardiovascular health, but also, focusing on intuitive eating practices and utilizing other determinants of health, like their mental health, their labs, energy levels, their lifestyle, which can almost always use a change in adult world. Also collaborating with a CF specialized mental health coordinator or social worker. We are lucky enough to have one on our team, which I think it's actually a need. I think everyone has to have one, but utilizing their help. This person is dealing with a lot of their, just body dysmorphia is what I would say. And I think that it would be really helpful to get that involvement on the social work and mental health coordinator side as well. But referral to a specialized eating disorder dietitian as appropriate, which I have done myself. I am not going to pretend to be an expert in treating that. And I think that there's a lot that goes into it. So referring someone to someone who specialized in that is very important. So GI changes. Obviously, we talked a lot about pancreatic function changes. There are some return functionality of the pancreas in the adult world. We do retest fecal elastase when appropriate. It is quite rare. The ones that we have done, they are still pancreatic insufficient, and it is severe. So we've been finding that the transition from insufficiency to sufficiency is quite rare in the adult population. What we have found was improved glucose levels and A1C levels in patients without CFRD, and an increase in bicarbonate secretion from the pancreas, which helps optimize the pH level of the intestines. And that also helps not only get off of acid suppression medications, but it allows a decrease in our enzymes, which we have seen that we have been able to do. Improved digestion and absorption, again, thinking long-term in terms of their diet and nutrition. Like I said, cardiovascular health, as our patients are living longer, we should be really focusing on, are their lipid levels, cholesterol levels elevated? How is their blood pressure? They're gaining weight and they're not losing as much salt in their sweat, and they're continuing to eat a high salt diet or that legacy diet. So those are important things to consider. Diabetes, again, with overnutrition and increased age, it does come with that risk. And similar to cerebrovascular disease, with overweight and obesity, hyperlipidemia, and lack of exercise. So lots of things to consider there when thinking long-term with, and weight gain and improved digestion and absorption of our meals. One thing that I have found that has been great is less oxidative stress, which I feel like is kind of that, head scratching. Where do we go with this in terms of people's symptoms that we've done everything we can to try to fix, but it hasn't really been completely resolved, likely due to inflammation. So with less inflammation, we're finding their GI function is getting a lot better, that their motility is improving, they're less bloated, fewer incidents of, diarrhea and constipation, their acid reflux is improved, which has helped wean off medications, and it does help correct with the dysbiosis that we see in CF. So in summary, in the adult world, I am trying to steer clear of the legacy diet as a standard practice in nutrition in CF adults. There may be some aspects to it that I do adapt to, like high calorie diets for a lot of my patients that are underweight and are having a difficult time gaining weight, but really focusing more so on well-balanced meals, even with those patients. So trying to get them to get high calorie, but also include that well-balanced diet of, lean meats, the fresh produce, heart healthy fats, whole grains, and fiber. Nutrition and diet recommendations must be individualized. I think this is a hill I will die on because I find it very important for everyone to get that individualized care. This is not, no one is like a classic textbook anymore in CF. It's very difficult to see everyone's changes and kind of monitor that. So personal calorie and protein goals, dietary changes, vitamin regimens, enzymes, medication changes. And I know a lot of siblings with CF kind of compare, and I do focus, this is individualized to you. You and your sibling will not require the same things. And that can be based on weight changes that you see, their pancreas function, if it returns or if it, doesn't return, their GI function, their mental health, etc. And then obviously weight gain being super important, or actually super common and important to handle with a lot of care. I think that it's a slippery slope to constantly be bringing it up for, patients that are already feeling, kind of insecure and having a poor body image at baseline. To constantly be bringing this up is difficult. And I know, with overweight and obesity rising in CF, we need to focus on body composition. And the amount of times I've said, well, muscle weighs more than fat, but that's just to kind of take them off of that edge. But it is the first thing that almost all providers talk about is, oh, their weight looks good. And I have heard of a lot of dietitians specifically using BMI and weight as another vital sign, like, oh, vitals look good. Great, don't need to discuss it anymore. Versus, oh, your weight looks stable. And then they bring up a whole slew of, oh, well, I've seen that I've gained weight, So I think it depends on if they bring it up versus how the team feels about bringing it up. But back to body composition, those types of machines are a little difficult and pricey to obtain. So we are still in the process of trying to consider where to get one and what's the best option. But that will help with body percent of fat and muscle to really say, okay, your BMI is this, but where is your weight coming from? That's the difference there. Body dysmorphia, very common in CF. There's a lot of risk factors like we talked about to consider when treating patients from a nutrition standpoint, but also from a mental health standpoint that is important to, the last line here, refer to a mental health coordinator or eating disorder specialist when appropriate if that is becoming an issue. Less focus on BMI goals and weight-centric care unless appropriate, and really just more focus on weight trends, their diet and what it's composed of, their lifestyle, and again, other determinants of health such as their labs, mental health, energy levels, sleep habits, hydration, etc. These are our references, and that is it. So any questions that anyone has? David will open it up to you.
Yeah, awesome. Thank you all for that informative presentation. And now we do have about 15 minutes left. If there are any questions from the audience, feel free to raise your hand or unmute yourself and ask, but also you can use the chat feature to submit any questions. There were a few that were submitted already, and we had a few that were submitted during registration that I think we covered, but maybe it's just worth re-asking and reiterating some of the information so that we can get to them. One was, do you suggest increasing protein intake on modulator therapy?
I have not, I don't know about Lauren and Jillian, but I have not specifically recommended an increase in protein specific to the modulator itself, more so for that well-balanced diet and to make sure that Muscle health has a lot to do with lung function as well, or muscle gain has a lot to do with lung function and pulmonary health. So including it in every meal and snack, yes, but if I calculate it, it's based on their, more of a weight-based thing versus a modular specific recommendation.
Great.
Yeah, I would say the same for us. It's definitely different patient by patient, but we same thing as Jess. We kind of don't prescribe it just because they are on a modulator.
Awesome. And it looks like Allison Burrows has a question from the audience. If you'd like to share your question.
Hi,
Hi,
ladies.
Allison.
Hi. I have two questions for you. The first one's a little bit more directed towards Jillian and Lauren, and then the second one's kind of to all of you. For the 30% of patients in the pediatric population that either turned pancreatic sufficient or had some improvement, was there a difference between age? So did the younger ones, were they more likely to be in that 30% than some of your older pediatric patients? Meaning, do they have the benefit of highly effective modulators early?
Yes, and you're exactly right. Younger population and also those who were started on Orkambi right away and then transition to Trikafta, then seeing those become more pancreatic sufficient.
Okay.
Yeah, and so that's probably also largely why we are seeing kind of more of an improvement in pancreatic function versus Jess's population, who was not able to get Trikafta until 2019, whereas our patients are starting it at a much younger age. So that's probably why we're seeing a lot of kind of difference in pancreatic function between the adult world and the pediatric world.
Okay. And then my second question is, even for those who are still pancreatic insufficient, I guess, like, is it worth it, even if you have a low fecal elastase test, just to kind of play with the enzymes and see how you would get to a quote comfortable level safely? How would you do that?
Yeah, I think that's something that we would start to look into as long as patients continue to grow well. Of course, with our kid population, wanting to make sure meeting weight goals every visit and that we're not seeing a dip. But with those GI symptoms, correct, like even if they are still severely pancreatic sufficient, maybe they're not having as much GI symptoms and needing the highest dose of enzymes.
I was going to say too, I've been finding that pre-Trikafta, they had what I feel is like inflammation and oxidative stress that was causing a lot of their GI issues, that we were trying to add on some caps for enzymes to try to help to see if that was changing it. So in my mind, I've been finding that I felt that we were perhaps overdosing on enzymes to kind of compensate for the adults that are kind of experiencing this extreme inflammation in their gut. And now that that's kind of resolving, I've been finding that we can decrease caps and using more fat gram dosing. But again, I find fat gram dosing to be a little dangerous territory with people who are experiencing body dysmorphia and body image issues. So I try to steer clear from that and kind of just say, oh, I like to classify it as one cap will cover X amount of grams of fat to kind of put it into perspective, because a lot of my patients don't find that there are toxicity levels. They don't seem to kind of click with that in terms of, what we don't want them to be overdosing in terms of the lipase. But I do feel that I start with the snacks at least, and then I kind of go cap by cap, because it's really difficult to get adult patients to answer my phone calls and respond to my things. So I don't like to just, decrease and like send them on their way. But I do kind of go cap by cap, and then I check in as frequently as I can, because I don't want to just, let's cut it in half. And then they're dealing with these GI issues and they're so used to it that I would be worried that they are A, malabsorbing, but B, they may not reach out as quickly as I would want them to. So I typically go cap by cap if I find that there's room to go down. But I generally find that if they are decreasing their fat content significantly in their diet, that we do have room to go down as well.
Okay. Thank you. That's helpful. And you got to call the moms. For the adults to just call the moms first.
Oh, I've tried.
Thank you. Thanks, all of you.
Thanks,
Allison. There was another question that was submitted online, and I think if this is more appropriate to be directed to their healthcare professional, please let me know. But one of the question was, how do you suggest losing weight after ETI weight gain? And the second part to that was, do you recommend GLP-1s or GLP-2s for people with CF needing to lose weight? I guess that's a very popular drug right now, and how does that affect the CF community?
It is. I'll take that one because I hope to God that Jillian and Lauren are not dealing with GLP-1s on their end. But the adult population, a lot of, it is a hot topic. Obviously, the nutrition recommendations I discussed in this presentation are my starting point. And it is pretty astounding how much change could be done to diet and exercise to help facilitate weight loss, that people, not everyone, but a lot of people get really frustrated. It doesn't happen right away. So they either give up or they steer towards quick fixes, which GLP-1s have been shown to provide that. The interesting thing with GLP-1s that I don't like, and I know my providers that are likely on this call can understand why I just have a distaste for them in general, but basically what they're doing is releasing a hormone that is basically slowing down your motility, which, God help me if we add more GI stuff to my CF patients' lives. And I think that it's going to get very interesting when if they start GLP-1s, if they do experience those GI manifestations of GLP-1s that a lot of people have heard about now. I think that constipation will be a thing, and overflow diarrhea, and they already have so many GI issues that I would not want to put something in their body or give them something that would slow that even more. And it facilitates a decreased appetite. That's kind of what GLP-1s do to an extent. This is not like the scientific version of it. But in addition to that, a lot of weight that is lost is muscle. And that is also something that is very correlated with lung function. So my first line of treatment here would be diet and exercise. And another thing too is GLP-1s are not a lifelong drug. And if you don't learn your habit changes, you're going to get off of that drug and probably gain that weight back. It can be used in correlation with changes for people who really can't get under a weight, or under, if they are focused on BMI goals in clinic. For some providers and doctors have recommendations on maybe we should start this. If they aren't able to kind of make changes while starting that, I wouldn't suggest starting there first with GLP-1s.
Awesome, thanks. And again,
I think another thing to note with that, just we're not really seeing this with the pediatric population, but what Jess was talking about, with the GLP-1s, it can cause a lot of nausea, and also like that decrease in appetite is pretty much the main thing that is also contributing to decreasing weight. And it sounds like, Jess and all dietitians with their patients in general are really trying to get our patients to listen to their body's hunger cues and really pay attention to when their body is telling them that they're hungry, and making sure that they're eating to feeling full. So it's it would be a little bit counterintuitive to what us as dietitians are trying to teach our patients in listening to their body's hunger cues, to kind of confuse their brain on when they are actually hungry.
Thank you. And again, always refer to your personal care physician when considering anything like that. But one of our last questions that came in online, are there any potential long-term metabolic effects for CFTR modulators on developing cystic fibrosis-related diabetes?
I found that question quite interesting. Studies out there have been actually shown that modulators actually improve glucose levels and A1C levels. Obviously, we don't use A1C as strongly for diagnostic purposes in CF because of the high red blood cell turnover rate that we see in CF. So it can falsely lower A1C, and we could be missing a lot of CFRD. So that's why the oral glucose tolerance test is the gold standard. But we have been seeing that modulators actually improve some of the OGTT results. But in terms of long-term effects, CF-related liver disease is something that is correlated with modulators, and that is why all of our patients get their LFTs, their liver function tests, tested so often. And liver disease is actually correlated with CFRD. So I think that we don't know enough about the long-term effects of specifically Trikafta. So I think we'll know more, but I would say it could increase risk, but it could also improve risk. So I feel like there's a weird in between there that we're not sure of yet. And hopefully we'll find out more with more research.
Awesome, thanks. That was about it for the questions online. Are there any further questions from the audience? We still have a minute or two left. Feel free to come off mute and ask your question. And if not, we will always give you back a few minutes back into your lunch hour and the rest of your day. But again, I would like to thank Jessica, Jillian, and Lauren for a really informative presentation and sharing this important information on changes, with our CF community, because, obviously we're experiencing a lot of change in the last, since 2019, especially. And this is, always a topic of interest. So again, thank you all for presenting today and sharing this information with the community and keeping us engaged and informed. So without further ado, I will say thank you one more time and enjoy the rest of your day, everybody.
Thank you, everyone.
Thanks for having us, David.
Thank you.